Bismillah ar-Rahman ar-Rahim. First of all, I'd like to thank the organizing committee, especially Dr. Sharqawi. Today, I'm going to present a very rare case. I hope if any one of you have seen similar cases. باشا عايز اسلايد اللابتوب على طول.
السهم يمين او شمال.
Okay. These three different patients, I've seen them. They're at the age of 30. They stated that this is the way they're living, this is the way they're walking since childhood. The etiology is really unknown. We've been searching the literature how a boy that's been living normally till the age of 7 to 10 gradually starts to have flexion only at the knee. He has normal hip and normal ankles. If you see how this boy is walking, the flexion deformity is about 140 degrees. And we have no clue why is this deformity happening. Have any of the professors here seen such cases? Yeah. Did you reach the etiology? No. No. At which age can you extend it with the general anesthesia? It's very tough. 50 years old. When did the problem started? No, I'm talking about gradual, progressive flexion deformity of unknown etiology. He has active knee extension with good power. Normal hip, 100% normal hip, 100% normal ankle. Okay? Yeah. But in such cases, we couldn't reach any range under anesthesia. Bilateral, symmetrical, again, if you see how the patient is walking, I'll show you the x-rays. We assume that it's a contracture of the capsule of the knee. But we searched the literature, we found that reports about severe flexion deformities of the knee. Yeah. Patella is in place 100%. Patellar dislocation starts very early. No, the quadriceps is over-lengthened. Okay. In such cases, the three cases are not the same. One of them had joint destruction. Okay, we assume that this may be due to infection or TB or something like this. But the other two cases has normal plain x-rays. Okay? In the literature, we found that most of the literature talking about severe flexion, it's either a pterygium syndrome or arthropotics, but none of which had normal range when they were below the age of 8, and they started this occult way of walking by the age of about 10, and it progressed to the maximum by the age of 15 to 20. Okay? In such cases, I think that no way to use casting under GA. It's really very tough. Okay? And the clue was, would they have a normal knee after correction or not? These are the papers that have been talking about flexion deformities of the knees. All of them were talking about either arthropotics or pterygium syndromes. This boy, he's from a nearby country. He's not an Egyptian. The 3 cases are not Egyptian by chance. Sorry? Polio doesn't cause this deformity at all. But poliomyelitis has a pattern that starts mainly in L4, and mainly the first muscle to be affected is the tibialis anterior. And if you want to have a knee affection, it's mainly in quadriceps. This doesn't, but this is not a polio by any means, because we have very good experience in polio. We're in Egypt, okay? But this is, we thought it's something neurological or something that has got something to do with the capsular contracture. Okay, after few investigations, we couldn't reach a mere diagnosis, and we decided to do the correction. Just remember how he was living. He was walking under the table. He was living a normal life. He used to go to work like this, okay? Of course, we used, this is on the day of the operation. This is a 30-year-old male. We used the Elizarov, and utilizing the tips of Dr. Ibrahim, how to put the hinges. They should be tailored to cause distraction so as not to have jamming of the joint while correction. Also, we should do an anterior thrust of the tibia, because here the posterior cruciate is very tight, and when we're doing the correction, there would be a posterior subluxation of the knee. These are very crucial during the correction with the Elizarov. Here is the final. If you see, the tibia is well located. It's a bit translated anteriorly because we've been keeping it, pushing it anteriorly so as not to subluxate posteriorly. Remember, this was the original position, and this was at the end before the removal. When we do the removal, we only put him, no osteotomy, of course. It's just a joint distraction with correction. And when we're doing the correction, as Dr. Ibrahim said, you should put the hinges in a way that it causes distraction with the correction. And also, it should put some anterior thrust on the tibia as if you're translating it anteriorly so as not to subluxate posteriorly, to resist the tension by the tibialis, by the posterior cruciate ligament. Of course, very fast. It only took about 4 to 5 weeks. Because here, the problem is the soft tissue, and the vessels and nerves is not a point at all. Here, we don't aim at osteogenesis. You don't have to go with the 1 millimeter and such things. Correcting a deformity, you should go very fast. It depends on the patient acceptance of the degree of the pain. Sorry?
So there is a degree of posterolateral rotatory knee subluxation and the patellar
In the second
dislocation.
case, there was, but in this male, there was no rotational problem.
No, even in this case. So there is a rotatory subluxation with the patellar dislocation. So this might be the cause of
You're saying patellar?
Yes, a dislocated patella. If this is an AP view.
Maybe the view is only in...
An oblique view?
Yeah,
Okay.
but I have a series of x-rays, none of which has rotational problem.
But the knee joint is not perfectly congruent, so this might be the
Because
cause.
he's been for years walking like this. Okay?
Dr. Hassan, please take your time.
Okay, sorry. Now, this is how he's been at the end. He started to walk at first with crutches, okay? He's now a tall man. His name is Marwan. He's now a very good friend to me.
What about the range, Hassan? The range?
Surprisingly, he has a good range. We're aiming at maintaining the extension. We allowed flexion till 45 or 50 degrees. Okay? He used to use the braces only by night. Now, I'll show you how he's very happy now, how he look very handsome. At the start, he had the good muscle power.
Conclusion, jump to conclusion, please.
This is the second case. This boy, he's not a boy, he's a man. He's also 28 years old. He has a destroyed joint. And here the challenge was that after correction, what to do? Okay? This is how he used to walk. He's from a nearby nation too. He's not an Egyptian. Okay? This man has a completely destroyed joint. The lateral femoral condyle is proximally migrated. But we decided to do him the correction and schedule him later on for a total knee replacement.
ده كان عنده hip dislocation كمان؟
No.
No.
Normal hip, normal ankle, but a destroyed knee.
دكتور حسن بليز
حاضر أنا
بليز
خلصت.
jump to conclusion.
Conclusion. This is the 3D CT. You can see the 3D CT. The joint is completely distorted. This is the after correction. This is after the correction. He's walking independently. Harder. This is Marwan, the boy I showed you in the start. He's 30 years old. This is in the feast. He sent me his picture. He's almost normal. Thank you, Dr. Ibrahim.